Welcome to Chalkwalks. Hi, in this case we're going to discuss a 14-year-old Maine Coon cat weighing about 5 kilograms who has a one-day history of acute neurological signs including head tilt, weakness, head pressing, and very importantly neck ventriflexion. On the differential diagnosis, before we get to the details of the lab data listed for you here, they had hyperthyroidism, and you'll see the reason for that is very clearly T4 was elevated, and T4 being elevated there's very few things that falsely elevate it in a cat. And the cats are about the right age. 14 years of age is pretty much the median age where you see hyperthyroidism. Mild chronic renal disease, which is based upon the creatinine. Hypokalemia, as you see, is clearly documented both on the quick lab test but also on the laboratory test, 2.3. And as a result, they suspected hyperaldosteronism and submitted an aldosterone. And we'll talk about what you can see in cats together with or separate from hyperthyroidism with regards to hypokalemia and the increasing recognition of the condition of hyperaldosteronism. So let's take a look at what was done for therapy. First of all, they targeted rehydrating the animal, gave 100 mils of lactating ringers, and then followed that with a maintenance rate of LRS with varying degrees of potassium supplementation, which we're listing for you here and down this list. Very importantly, since the cat was eating, and most cats, hyperthyroid cats, will eat, they supplemented in the food oral potassium gluconate. Potassium can be supplemented very safely orally, and they gave 0.43 milliequivalents per kilogram every 12 hours. And if you look at the actual normal dietary intake of an animal and to maintain requirements of potassium, the figure is around 2 milliequivalents per kilogram per day. And so this is roughly speaking, handling 40 to 50%. Some cats can have issues with too much potassium given orally, but this is a very safe way to try to sustain an animal. And I don't have it in the record, but the cat was probably eating a little bit. And because they suspected hyperaldosteronism, they used a drug called spironolactone, which is an aldosterone receptor antagonist. And we sometimes or more commonly see this drug being used in the context of animals that are being treated with diuretic therapy, say for congestive heart failure or mitral valve insufficiency, and where we find the loop diuretics lead to too much hypokalemia, and an aldosterone receptor antagonist is used in that scenario to be a potassium-sparing diuretic. Because this cat had evidence of some pain, they used the opioid agonist buprenorphine as needed. So let's take a look at what actually happened, and we'll show you in the next image here some guidelines for potassium replacement. The first thing I'd point out that hyperthyroidism, because of the metabolic dysfunction, hypermetabolism, and in some cases muscle damage that can occur, you notice here the creatine kinase is quite elevated, so I would say this is possibly a reason for damage to muscle, release of this enzyme, release of a lot of potassium. And so this cat may have lost potassium in that way as well. So we don't have to postulate hyperaldosteronism. So we started out low, and they started relatively what I would call fairly aggressively maintaining or administering into the IV fluids potassium chloride at 85 milliequivalents per liter. And you can see, we do see from the point of starting that, that we did see an increase, and eventually sustaining of that. And we're only able to reduce when we got to the addition of spironolactone. So there may be some evidence based on the ability for spironolactone to sustain the normal kalemia, that in fact there was a hyperaldosteronemic condition here. Unfortunately, at the time we looked at this case, we don't have the record of the actual results. And those results need to be, aldosterone always needs to be interpreted in light of what the dietary intake is. So take a look at this animal's potassium administration. As we mentioned, at the highest point it was being given 85 milliequivalents per liter of potassium added to the fluids, and we're just going to, and assuming that this was at a maintenance fluid rate of 50 milliliters per kilogram per day, which to translate per hour is 2.1 milliliters per kilogram per hour. And I put here a little table that you'll find in a lot of different places that can help guide you to address potassium in a dog or a cat particularly. Bear in mind that potassium, when it starts to be low, it's probably already around 20 to 25% deficient, because potassium is an intracellular cation. And so you can see that the figure that this table, so you see various recommendations for how much potassium you could add based upon where the potassium sits. And we had an animal that was sitting in this range, so you can see why I said this is a fairly 85 milliequivalents per liter, is pretty aggressive, but nonetheless it seemed to have worked. But we need to bear in mind that we have a maximum administration rate of potassium given IV that should not exceed a half a milliequivalent per kilogram per hour. And just to put it into perspective, and I calculated this, that this cat at maintenance rates was given 2.1 milliliters per kilogram per hour. So we are sitting at about a third of the maximal rate. So if you had that fluid, let's say the cat was not on a pump, but had a very positional catheter, you could run in potassium in. Of course, the concern for too much potassium is third-degree heart block. Well, it'll go from second degree to third degree heart block, and then asystole. So you can kill the animal if you're not careful with this. So at some point you probably want to monitor the ECG, and certainly potassium monitoring as you go along, which you can see they did in this case. Now the reason I also listed here the pH is that there are situations, particularly in acidosis, where you can see shifting of potassium from within the cell exchanging with hydrogen ions outside the cell, and this can lead to a falsely elevated potassium, or in this case, once we start, and we can see that if anything, we have a slight alkalemia, so that wasn't the case. Maybe a slight acidosis at the beginning, but once you started giving lactated ringers and rehydrating, that kind of went away. And everything seemed to be pretty stable after that. But do pay attention to the pH because the acidotic animal will have sometimes, relatively speaking, a higher potassium than they really have reflecting on their body, in their body as a whole. So just some guidelines on managing potassium. In this case, in a cat, you can run into the same issues in cats that are blocked, where they have a post-obstructive diuresis, and you have to be very aggressive with your potassium administration. But I thought this was a general enough problem that you see in small animal medicine that it was worth talking about.